Well, welcome everyone to the Minneapolis Heart Institute Foundation's On the Pulse series. I am Chris Fortman, lucky to be the CEO here at the foundation. And I would like to let everyone know that it is the season of giving here, as always, but we are celebrating 40 years of phenomenal cardiovascular research and education. And as a 501c3 nonprofit organization, we rely on donations to make this fabulous work happen. So if you're still thinking about your end of the year giving, we so would appreciate you going grateful with us and considering making a gift to the foundation. Now, today we are going to hear from Dr. Elizabeth Tuohy. She is a cardiologist at the Allina Health Minneapolis Heart Institute and serves as medical director of the Heart Disease Prevention Clinic in St. Paul at United Heart and Vascular Clinic. She earned her medical degree from Loyola University School of Medicine and completed internal medicine residency and cardiovascular medicine fellowship training at Northwestern University in Chicago, Illinois. Dr. Tuohy's cardiology practice interests include heart disease prevention, complex lipid management, general cardiology, as well as interpretation of multiple modalities of non-invasive cardiac imaging, including echocardiography, nuclear imaging, and cardiac CT. Dr. Tuohy is also active in teaching the United Family Medicine residents during her inpatient rounding service at United Hospital. She is a member of the American College of Cardiology, American Heart Association, and National Lipid Association. Dr. Tuohy sees patients in St. Paul, Hastings, and Shoreview, Minnesota. Please help me welcome Dr. Tuohy.
Hi, thank you so much for the introduction, Chris. I am the medical director of the Heart Disease Prevention Clinic at Allina Health Minneapolis Heart Institute in St. Paul. And as part of that work, I am passionate about looking at what are the risk factors that people have that put them at risk for heart disease so that we can address that ahead of time. And one of the important risk factors for heart disease is high cholesterol. So today I'd like to discuss with you what's the big deal about cholesterol. We will review basics about cholesterol and lipids. We'll discuss the prevalence of high cholesterol, or how common it is in our society, the risks of having high cholesterol and what determines our cholesterol levels, as well as the benefits of cholesterol lowering and how we go about lowering cholesterol levels. So first of all, what is cholesterol? Cholesterol is a waxy, fat-like substance primarily made by our liver. Blood cholesterol is important for us. It's essential for building cells, making hormones, and helping to digest fatty foods. However, frequently our body makes much more cholesterol than we really need, and too much cholesterol is harmful as it can lead to plaque buildup in the blood vessels. When you get your cholesterol level checked, you might hear that it's referred to as a lipid panel. When we check this lipid panel, we're looking at cholesterol levels as well as the levels of other fats in our bloodstream. We check, and I'll review with you later what each of these things are, but the list of things that are checked include total cholesterol, low density lipoprotein, or LDL, high density lipoprotein, HDL, triglycerides, very low density lipoprotein, VLDL, and that's probably new in the last year or two that within Allina they've been checking this level routinely. The lab also reports non-HDL cholesterol, which is simply the total cholesterol with the HDL subtracted. And the lab reports the ratio of the total cholesterol divided by the HDL. So what's a lipoprotein? This is the amazing way that the body transports cholesterol and other fatty substances throughout the bloodstream. If you think of oil and water, they don't mix. So similarly, cholesterol or fat in our blood wouldn't mix well with the blood, which is primarily water-based. So a lipoprotein is a particle where all of the cholesterol and fatty substance is contained within the center, and then on the outside of the particle are proteins that are able to interact with the watery blood. The fatty substances are held inside, and those proteins on the surface of the lipoprotein help direct it in the body as to where it goes. It's pretty incredible. And this part isn't important for you to know, but if you are curious about why these particles are called high density or low density or very low density, it has to do with the particle size as well as the density of the particle. HDL, high density lipoprotein, is the very smallest particle, and it's the most dense. It has the least amount of fat in it, so it's heavier. That's why it's called HDL, high density lipoprotein. Low density lipoprotein is lower relative to the high density. And then there are other particles as well called IDL, which is intermediate density, VLDL, very low density. This is the protein particle that carries triglycerides in our bloodstream. And there's another one called chylomicrons, which is the lowest density and the largest. After we eat a meal that contains fatty substances, it gets taken up into chylomicrons and circulated. We don't check those levels routinely, and that's out of the scope of the talk today. We're really going to focus in on HDL and LDL. Normal cholesterol levels are listed here. A total cholesterol level should be under 200. HDL should be over 40 for men and over 50 for women. There's newer research that suggests that it probably should still be under 80 though. Excessively high levels of HDL might not be beneficial. Triglycerides should be less than 150. LDL should be under 130 at least. Some would argue under 100 is normal for all people. And in people who've had heart disease or other vascular conditions, we try to get that LDL as low as possible. And we'll review that reasoning why later. A normal VLDL level is less than 30. LDL, low density lipoprotein, is also sometimes referred to as the bad cholesterol. It transports cholesterol particles throughout the body, and that's an essential role. Our body does need some of that cholesterol. However, when there's too much, the excess can build up in the walls of the arteries, making them hard and narrow, a process called atherosclerosis, which the term comes from the Greek words athero, meaning gruel or paste, and sclerosis, or hardening of the arteries. Plaque is a mixture of cholesterol, fatty substances, cellular debris, inflammatory cells, and fibrin, which is a clotting material in the blood, which grows within the inner wall of the artery. When that plaque forms in the arteries of the heart, that's called coronary artery disease. The coronary arteries shown here lie on the surface of the heart and feed the muscular walls of the heart itself. The top drawing shows a normal artery where there's no plaque buildup with normal blood flow to the heart. But plaque can form within the walls of the artery and start to obstruct the flow. And that's where people might start to get symptoms with exertion, such as getting chest discomfort or shortness of breath with activity. And the way heart attacks happen is that a plaque becomes unstable and the cap of it ruptures open where a little raw wound is exposed, and the body clots it off, where all of a sudden the vessel is totally occluded, totally blocked, and that results in a heart attack and damage to the heart. But plaque buildup can occur throughout the body, not only in the heart. It can occur in the carotid arteries of the neck and the brain, increasing the risk for strokes, vascular dementia. It can occur in the aorta of the chest, increasing the risk for aortic aneurysm, which is an enlargement of the aorta. It also can affect the blood flow to the internal organs, like the kidneys and the intestines, leading to reduced blood flow to those organs. And also in the blood vessels of the arms and the legs, which we call peripheral arterial disease, where people get blockages in the extremities, they can have pain with ambulation or just difficulty with arm discomfort when they use their arms. So plaque can form anywhere throughout the body. And this is a really important key point about low density lipoprotein and the relationship it has with building plaque formation or atherosclerosis. Now this is a detailed graph that I'll explain to you. So on the x-axis, the bottom line, over on the left are people who had lower LDL levels, around 50 to 60, and then increasing levels of LDL up to the highest range here of 150 to 160. Above the 0% mark are people who developed atherosclerosis, and below are those who did not develop atherosclerosis. So you can see that the patients who had low LDLs, 50 to 60, none of them had atherosclerosis. And as the LDL levels increase, there's increasing development of atherosclerosis. And the different colors are the green, orange, and blue meaning how many we call it vascular beds the plaque formed in. One vascular bed would be the heart only. Two would be, let's say, the heart and the legs. Three would be the heart, the legs, and the brain. So with higher levels of LDL cholesterol, there's more atherosclerosis and more areas of the body are impacted. And it is important to note that some people with higher LDLs still did not develop atherosclerosis. So cholesterol is only part of the puzzle or part of the story of what causes plaque, but there's a very clear, well-established relationship that the higher the LDL is, the more atherosclerosis and the more spread out throughout the body, its location. And having atherosclerosis is also then associated with an increased risk of dying from cardiovascular disease. This graph shows over time, over the follow-up of 10 years, what the percent chance was of dying from cardiovascular disease, comparing people with different levels of LDL cholesterol. You can see that those with the highest level of LDL, over 190, certainly had the highest risk of dying from heart disease. Those with the lowest LDL of 100 less, they had the lowest risk, and it increased gradually with increasing amounts of LDL cholesterol. So there's a clear relationship that the higher the LDL, the greater the risk of heart disease and dying from heart disease. HDL, high-density lipoprotein, is also referred to as the good cholesterol because its function is to pick up excess circulating cholesterol particles and direct them back to the liver for the body to break it down. So by having normal levels of HDL, that protects against artery plaque because it's moving the plaque-forming cholesterol particles out of the bloodstream. However, if you have low levels of HDL, then it's not doing the work of getting rid of those other cholesterol particles, and the other cholesterols can contribute to plaque formation. Recent studies have shown that very high levels of HDL, probably over 80, certainly over 100, is actually associated with increased risk of heart disease and death, particularly in men more so than in women. And it's thought that the reason for this is that excessively high HDL may not be functioning normally. It might be out there circulating but not working well. There's too many of them not doing their job. So it's important to note when we interpret the total cholesterol to HDL ratio to make sure that HDL is actually still within a desirable range. If the HDL is excessively high, it might not provide that benefit and your ratio might look better than it really is. So when I look at the cholesterol panel, I don't focus as much on the ratio as I do the actual levels of the total cholesterol, LDL, HDL, and so on. Triglycerides are a type of fat that our body uses for energy. When we have excess, too much triglycerides, though, that also is associated with an increased risk of heart disease. And very high levels, over 500 or certainly over 1,000, can cause pancreatitis, which is inflammation of the pancreas, which can be a life-threatening condition. High triglycerides are more common in people who have a high carbohydrate, high sugar diet, or in people with diabetes who have high blood sugars. When there's excess sugar, it gets pushed into forming triglycerides. High intake of alcohol can also cause that formation of triglycerides. And there are genetic conditions as well. Very low density lipoprotein, VLDL, normally carries fats such as triglycerides to the cell to be that source of energy. When we have too much triglycerides, to carry it around, we need more VLDL. So elevated levels of VLDL are seen commonly when people also have higher triglycerides. And that overall excess burden of triglycerides and VLDL increases the risk of cardiovascular disease. So now that we've learned about the basics of cholesterol and lipids, let's talk about how prevalent high cholesterol is. It is extremely common. This is data from the CDC on the prevalence of cholesterol levels over 200 in men and women of various ethnicities, non-Hispanic white, non-Hispanic black, Hispanic, and non-Hispanic Asian, comparing 2015 to 2016 in the blue bars and 2017 to 2018 in the red bars. This is the most recent published data. What you can see overall, I guess the points I'd like to highlight are there has been an improvement in cholesterol across all groups here, And that's actually been a trend that's been going on for about 10 years where cholesterol levels are improving in the United States. And it's not totally clear why that is the case, but it's thought to be because there's been such a big push to getting trans fats removed from our foods. So getting rid of those trans fats has been one of the key things that has helped, is what the main theory is. But as you can see, 30 to 40% of men and women across all ethnicities have high cholesterol. So it's very common. Non-Hispanic Black individuals have a little bit lower than average, where they're more in the 30 to 35% range. But nonetheless, that's similar 35 to 40% amongst all subgroups. So it's not thought to be that race is a huge determinant of cholesterol. There are other parameters such as our foods, our weight, and other dietary measures that contribute to cholesterol levels. Here's a map that also shows the prevalence of high cholesterol from 2018 to 2022. And you can see that there's a lot of variation based on where we live. Part of that is genetic, part of that may be race or ethnicity based, and also a part of it is probably related to food practices and lifestyle measures. So what determines our high cholesterol or our cholesterol levels is amazingly only about 20% is from our diet. The other 80% is how our body produces and metabolizes the cholesterol. The majority of our cholesterol is made in our liver. And the factors that go into that are complex, hereditary factors and gene mutations that can cause us to either produce way too much cholesterol or not metabolize it well, leading to abnormally high cholesterol levels. The food sources of cholesterol are found in animal foods, such as meat, seafood, poultry, eggs, and dairy products. But the actual cholesterol content isn't what is the primary driver of our blood cholesterols. What's important about these foods is that they are high in saturated fat and sometimes trans fats, which actually cause the liver to make more LDL cholesterol than it normally would. Saturated fats are also found in fried foods, baked goods, and in some tropical oils. I'd especially like to highlight coconut oil. Coconut oil has become rather popular as a plant-based oil to use for cooking. However, it is a saturated fat that has been shown to raise the LDL cholesterol. So I actually discourage the use of coconut oil and instead would encourage olive oil or other unsaturated fats. Because it is important that a heart-healthy diet can lower cholesterol by about 10 to 20%. And a heart-healthy diet has other benefits besides in cholesterol lowering. A heart-healthy diet can be anti-inflammatory and help with the heart functioning overall. But the dietary things that we can do to lower cholesterol are to increase our intake of soluble fiber. Those include whole grains like oats, barley, brown rice, my favorite quinoa, legumes such as beans, lentils, and split peas, non-starchy vegetables like asparagus, Brussels sprouts, cabbage, broccoli, cauliflower, tomatoes, peppers, celery, carrots, and leafy greens. So not the potatoes per se, but the non-starchy healthy vegetables are a great source of soluble fiber. And fruits as well can be a source of soluble fiber. So we especially encourage fruits that are lower in sugar, like berries. And then the other dietary measure we can do for lowering cholesterol is to replace those saturated fats with unsaturated fats. So choose olive oil, avocados, avocado oil, nuts, seeds, plant-based proteins instead of animal-based proteins, and avoid butter, lard, coconut oil, and fried foods. When a person has high cholesterol, though, and we've demonstrated that high levels of LDL are associated with a high risk of atherosclerosis, sometimes diet isn't enough to bring the cholesterol levels down to normal levels. And in this case, we most often, if appropriate, recommend a statin type of cholesterol lowering medication because there is robust medical evidence that shows statins safely lower the risk of heart disease. So let's review this information. There are 4 groups of people for whom it has been well established in the medical literature that statin medicines have benefit. This includes people who've had clinical atherosclerotic cardiovascular disease, which is the medical term for someone who has had a heart attack, a blockage that needed to be opened, a stroke, or blockages in the legs or arms called peripheral arterial disease. If people already have that disease present, then statins have a significant benefit. The next group are people who genetically have high cholesterol, with extremely high cholesterols, LDL over 190. We call this primary hypercholesterolemia, which is a meaning that the body is just making too much cholesterol or not metabolizing it well, without another cause. Oftentimes, this is caused by a genetic condition called familial hypercholesterolemia, where due to a gene mutation, the liver is either producing too much or not metabolizing the cholesterol. They are born with very high cholesterol levels, and a lifetime of high cholesterol is associated with a very high risk of heart disease, that of 3 to 10 times the average person. The third group who have been shown to benefit from statins are people with diabetes. Diabetes itself is a condition where there's high blood sugars, which over time is inflammatory and also can contribute to heart disease or atherosclerosis. So regardless of their cholesterol levels, people with diabetes also benefit from statin medication. And then the fourth group is anybody else who hasn't yet had a heart event. Their LDLs aren't exceedingly high, they don't have diabetes, but they still are at either intermediate or high risk of heart disease based on other risk factors. Things such as age, having high blood pressure, smoking is a big one, or people who find out that they have heart artery plaque based on medical imaging. They might have had a CT scan of their chest for lung cancer screening or for other reasons, and it shows incidentally that they have heart artery plaque. That's a time to discuss the pros and cons of being on statin. So let's review just a little bit of the data that exists about these 4 subgroups of people that benefit from statins, because there is so much medical research and data on this. I certainly couldn't share all of it with you, but I'd like to highlight some of the key points. In people with established heart disease, strokes, peripheral arterial disease, statin therapy, taking a medication like one of the many statins, reduces the risk of a cardiovascular event by 25% for every reduction in the LDL of 39. So if someone's LDL level was 140 and we get it down to 100, we've reduced their risk of a cardiovascular event by 25%. And if we get it down another 40 points to 60, to goal of less than 70, we've reduced their risk in half. So it's extremely beneficial. And that benefit is especially important long-term. If a person waits until they're 80 and they've had multiple heart attacks and stents, a lot of that atherosclerosis has happened over decades and we can't reverse it. But if we start earlier in life and their LDL levels are well controlled for decades, that can reduce their risk of dying from heart disease by 50 to 55%. And statins don't just lower the LDL, they lower the LDL, but in addition, when they've done studies of arteries with plaque, looking at them with ultrasound, statins have been shown to make the plaques get a firm fibrous cap to make them more stable, so they're less likely to rupture and cause that artery to block. And the plaque volume also has been shown to shrink. It doesn't go away completely, we don't know how to make it go away, unfortunately, but it does shrink down and makes the plaques more stable. So statins have benefits in that regard as well. When people have a cardiac event, they've had a heart attack and now have a stent, let's say, even if they have normal cholesterol levels, we still put them on a statin for that plaque stabilizing effect. The next group of people shown to benefit from statins are people with genetically high cholesterol, familial hypercholesterolemia. When the statin meds came out, they were utilized in people with this condition right away because it was well known that leaving cholesterol levels exceedingly high for years, that people died at a significantly higher rate of heart disease. So there was never a study where they had people with this condition take the drug or not take the drug, because it would have been unethical to withhold treatment. So instead, this study cleverly looked at what about, at the time, modern era people with familial high cholesterol taking a statin, and then compared that to a previous database of people with familial hypercholesterolemia who weren't on a statin. And they looked at follow-up over 12 and a half years, and compared the percentage of people who did not have a cardiac event. This is really important. So you can see that in blue, the people who were treated with a statin, their chance of surviving without a cardiac event was over 80%. However, compared to the group of people who didn't have access to the statin, their risk of dying from heart disease was significantly higher. After 12 and a half years, less than 40% had not had a cardiac event. So the statin medication was extremely beneficial in this subset of people. And they've also done studies looking at parents with high cholesterol and their children with high cholesterol, comparing those two, and they'll start kids as young as 10 or 12 on statins when they have this familial high cholesterol condition, because it does all the benefit for all of those decades to prevent plaque formation. The third group of people shown to clearly benefit from statins are people with diabetes. And this is one of many studies done in people with diabetes looking at the benefits of statin medication. In the left graph, on the x-axis, we have the years that the patients were followed, almost 5 years. And on the y-axis, it was the cumulative event rate of having a major adverse cardiac event, meaning a heart attack, having a blockage opened, a stroke, or dying from heart disease. And as you can see, people taking the placebo over time had more and more incidents of cardiac events. People taking a statin called atorvastatin, they still had heart events, but at a much, much lower amount. And that difference started to splay out over time, where the people on atorvastatin increasingly have more and more benefit as time goes on. That same study looked at this risk of dying, death from all causes over 5 years' time for people with diabetes taking placebo versus those taking atorvastatin. And the patients taking atorvastatin had a lower risk of dying from all causes. And again, that difference between the placebo group and the atorvastatin group increased over time, showing the benefit of long-term statin medication treatment. The fourth group are people who are at risk for heart disease due to risk factors. There's a lot of studies that look at this too, but this is one I'd like to highlight. It was called the Jupiter study, where they looked at healthy adults, actually not considered at high risk of heart disease. They were more low to intermediate risk. Their LDL levels were under 130, not high. But they had a blood test marker called high sensitivity CRP that was elevated. That's a marker of inflammation, and it's been shown that inflammation is part of what contributes to artery buildup. So these healthy adults with LDLs less than 130, but had high sensitivity CRPs over 2, opted to participate in the study to take placebo or rosuvastatin. And similarly, they watched these folks over just about 4.5 years and looked at the incidence of having a cardiac event or dying from heart disease. And overall event rates are relatively low over this short period of time of just 4.5 years in a pretty healthy population. But we still see the same trend that people on rosuvastatin had a lower risk of heart disease and lower risk of dying from heart disease. So we highlight the benefits of statins, and it's also important with any medication to acknowledge the potential side effects. What are the pros, but also what could be the cons? And the most common potential side effect from a statin medication is muscle symptoms, muscle soreness. This is an interesting topic for statin side effects because in the medical literature and in the medical practice, the risk of this and the severity of this is much lower and better compared to what we see sometimes in the popular media that exaggerates the negative possible side effects of statins. So hear me out about this. In the research trials, when they looked at side effects that patients had on their study drug, a statin, only 1 to 5% of people had muscle symptoms. But in real life, we do see that 5 to 10% of people complain or note of muscle soreness or muscle achiness. It's often very hard to know, is that because of the statin, or is it due to an underlying chronic back issue or other normal arthritis, aches, and pains? It's often hard for us as clinicians to know for sure with the patient, is it the med or is it some other factor, some other condition that's making them have muscle soreness? If it is the statin, thankfully it's reversible. So what we usually will do is have a person go off the statin for about a month, see if they feel better or not. If they do, great. Then we switch to a different statin, different dose, try something else, try to find one that works. I always tell folks, I want you to feel normal on your medication, get the benefit from it, and not have side effects. Interestingly, sometimes it's just people don't have, let's say, let me back up. So they might stop their medication and realize, oh gosh, my back still hurts regardless, it wasn't the medicine, and we go back on it. Sometimes that happens. Other patients truly have muscle pain from statins, and we have to try a different one, try a different dose to find something that might work. The predisposing factors for muscle side effects from statins are being older in age, women more than men, people with a low body mass index, so if they have a lower muscle mass overall, they're at increased risk. If people are on other medications that interact with the statin, so we always are careful to look at a person's entire medicine list to make sure we choose meds that don't interact, or if they have underlying medical conditions that already might contribute to muscle pain. And when they've done research trials, there's a phenomenon known as the nocebo effect. You've perhaps heard of the placebo effect, where if people take a sugar pill, they're thinking it's a medication, they feel better, they have a positive effect from that sugar pill. There's also the risk of nocebo effect, where people in studies on statins, when they've done studies comparing statin to the placebo, patients sometimes had complained of muscle pain at a similar rate to the people who were on statins. So by taking the sugar pill, thought that they had muscle symptoms. And it's a powerful effect that our brain has, where we can feel like taking something makes us feel worse or makes us feel better. So my key point with this is that overall, over 90% of patients take statins without any muscle trouble at all, thankfully. And of the 5 to 10% who do, usually we can find one that works, trying a different one, trying a different dose. The goal is that if you do take a statin, that you feel well. The risk of true muscle injury is very rare, less than 1%, and a severe muscle injury called rhabdomyolysis, where there's muscle breakdown that affects the kidney function, is exceedingly rare. That's 1 in 10,000 people. The other possible side effects from statins are the risk of diabetes. Statin meds can make the blood sugar levels a little bit higher. So if someone's already predisposed to having diabetes, such as being overweight with a BMI over 30, having impaired glucose tolerance, where their fasting blood sugars are mildly elevated over 100, or metabolic syndrome or pre-diabetes, those are the folks that can go from being borderline diabetic to diabetic. It occurs in 1 to 3 in 1,000 people. So it's not very common, but it does happen, and we do see that in clinical practice. When that does happen, usually we have a discussion about the pros and the cons and acknowledge that the benefit of the statin is so much greater than the slight difference in their blood sugar levels that we usually continue the statin medication, and then work on other measures to control the diabetes and prediabetes, like weight loss, diet, and exercise. Other statin-associated side effects can include significant liver injury, which is very rare. In the decades past, we used to check liver enzyme labs routinely, but we've come to learn through all the years of data that the risk of significant injury is so low that those enzymes don't need to be checked routinely. There are case reports of people who thought they had changes with cognitive or memory function. However, in large clinical trials, when they really compare and do testing on brain functioning on statins, there hasn't been any difference with being on statin or not. And in fact, there's some studies that show statins actually help prevent vascular dementia due to atherosclerosis in the brain. So cognitive impairment really is not a concern. And then you may have heard of reports of rare things which have actually been unfounded and not associated with statins, such as cataracts, tendon rupture, hemorrhagic strokes, lung disease, or low testosterone. Those are unfounded claims. In people who truly can't tolerate a statin due to side effects, or people whose cholesterol levels still remain too high despite being on a statin, then we also consider non-statin cholesterol lowering medication, such as ezetimibe, which is known as Zetia. That's a pill that's taken that limits the absorption of cholesterol and over time makes the liver process it more quickly. There are 2 injectable cholesterol meds called Prevalence and Repatha, alirocumab or evolocumab, which help the liver clear cholesterol more quickly. Bempedoic acid, Nexletol, which is a pill that's taken that slows the production of cholesterol. And another injectable medicine called inclisiran or Leqvio, which also helps to make the body not produce an enzyme that leads to the cholesterol being metabolized more quickly. So they work in different ways than statins and are newer than statins. Some of these have only been on the market a year or two. So we don't have the long-term data that we do with statins, but these have been meds that have been shown to be very beneficial in the appropriate setting. People ask about supplements. What supplements can I take to lower my cholesterol? I'd rather take a supplement than a prescription. Just this last month, there was a nice study that came out that showed us the data on this. In this study, people were prescribed either 5 milligrams of rosuvastatin or placebo or a supplement. And then the various supplements that were investigated were fish oil, cinnamon, garlic, turmeric, plant sterols, and red yeast rice. And those are common supplements that some people choose to take for cholesterol lowering. In this study, when people were on 5 milligrams of rosuvastatin, their LDL cholesterols were lowered by 35%. A good impact. And not one of the supplements lowered the LDL cholesterol. Each of them was similar to placebo. So from a standpoint of supplements, we have data that shows they do not lower the LDL cholesterol. My key points that I hope you've learned today is that high cholesterol is common. 30 to 40% of adults have total cholesterols over 200. High LDL is a significant risk for development of atherosclerosis. The higher the LDL, the greater the risk. A heart-healthy diet does have significant benefits, but only a modest effect on the cholesterol levels. The lower we get the LDL, the lower the risk. Statin medications have great benefit, and the benefit outweighs the possible risk of side effects, and those side effects are manageable. And supplements have not been shown to be effective in lowering LDL cholesterol. So my guidance or recommendation for you would be to know your numbers. It's recommended to get cholesterol levels checked at least once every 5 years, sometimes more often if people are on cholesterol medication or at higher risk or have other medical conditions. And when it comes to LDL cholesterol, the lower the better, the longer the better. So eat your vegetables and have a nice day. Thank you.
All right. Well, thank you so much, Dr. Tuohy, for that fantastic presentation. We really appreciate your time and expertise. And hello, everyone. My name is John Rickert, and I am the virtual event lead here at the Minneapolis Heart Institute Foundation. And thank you so much for joining us. I'm just going to jump in here and just help to facilitate the Q&A portion for today. And I will say we did receive over 100 questions through registration. So unfortunately, we won't be able to get to every single one, but I'm going to do my best to consolidate and to generalize these questions so we cover our bases here. So the first question has to do with diet. And Dr. Tuohy, I know you spent several slides on that, but if you could just repeat maybe the highlights of what is the best overall diet for lowering cholesterol and what foods are best.
Perfect. Yes, the overall dietary pattern that's been shown to be best for heart health in general, as well as cholesterol lowering, would be a Mediterranean style diet, or even more plant-based eating, where we avoid those animal products that are high in saturated fats like butter, lard, fried foods, focusing more on whole grain, plants and vegetables. Unsaturated fats are the better choices.
Perfect. Thank you so much for that. So on the flip side, again, I know you covered this in your presentation, but what type of diets are detrimental for cholesterol issues, and what foods should either be avoided entirely or consumed sparingly?
Right. The saturated fats are indeed not healthful. They can increase LDL cholesterol. So avoiding those animal marbled meats, brats, cheese, pizza, keeping that stuff to a limit. And I also want to highlight sugar. Today's talk was really focused in on cholesterol, but a high sugar diet also is unhealthy for us, increases the risk of diabetes, promotes weight gain. So trying to eat more of a natural whole foods diet is very important.
Perfect. Thank you, Dr. Tuohy. And I do know there were several questions about sugar, so I appreciate you tying that in as well. So we talked about diet. What about exercise? Can exercise in general help to improve cholesterol? If so, what sort of exercise would you recommend to patients with high cholesterol who are able to exercise? And is there any exercises that should be avoided?
That's an interesting thought. Yes, exercise is beneficial to the heart in general for heart conditioning, but it also helps to increase our metabolism. For some people, it can help with managing weight, and keeping weight down helps to keep cholesterol well controlled. Any form of exercise is good. It's recommended that all of us get 150 minutes a week of moderate activity, like walking at a minimum. And then if we do aerobic activity, to get 75 minutes a week. So whether you like being on a recumbent bike if you're unable to walk, or swimming, or dancing, or lifting light weights with higher repetitions, all of that is good for heart health.
Absolutely. Thank you so much for that. So, on a similar note, we're talking about lifestyle choices. So there are there other lifestyle choices other than diet and exercise that can influence cholesterol levels? For example, this attendee had given the examples of smoking or alcohol, stress, occupation, things like that. Could you speak to that?
Yes, indeed. Alcohol highlights, I would highlight that one as a high risk in that when people drink alcohol in excess, it can make triglyceride levels significantly high. And today's talk was pretty brief to really zoom in on, we didn't have a lot of time to talk about triglycerides, but when triglycerides are high, that can cause pancreatitis, which is a very risky condition. So keeping alcohol in moderation is important. Smoking is detrimental in its own effect on the arteries. So it's hard to comment on that other than we shouldn't smoke or use any nicotine products. It's not good for our bloodstream.
Yeah, makes a ton of sense. Well, I appreciate that. And parlaying into some other areas of questions here. So I know you talked about high cholesterol being inherited. Is there anything else that you'd like to say to that? Or even, if someone is predisposed for high cholesterol, is there anything that they can do to avoid, having that become a problem?
Right. That really depends on the type of genetic inheritance it is. That condition I referred to called familial hypercholesterolemia, that's a gene mutation that's passed down from one parent to the child. So you get it from one parent. If each kid has a 50% chance of getting it. And the gene mutation is so severe that it results in extremely high cholesterol levels, regardless of lifestyle. So I've met patients who have this who are vegan marathon runners with a low to normal weight, and their LDL cholesterol is still 250. Those folks, it's due to a gene mutation that no lifestyle measure will control. But for the most of us, that condition affects 1 in 200 people or so. But for the other people, there's multiple different genes that are involved in cholesterol metabolism. And for some, diet and lifestyle can make a much greater impact than for others. So there's a lot of variability from person to person. But sometimes if people are eating well, exercising, they're a healthy weight, and they still have high cholesterol, that often is a genetic driver.
Thank you very much for that, Dr. Tuohy. So can cholesterol be too low, or is there a patient population with high cholesterol who are not at risk for health problems?
Interestingly enough, it's rare, but there are people with high cholesterol levels who never develop artery plaque, and it's not fully understood why. To the other end of the question about is there such a thing as too low cholesterol, the answer is probably not. Either when they've done population studies on families who genetically have extremely low cholesterol, they have a very low lifetime risk of heart disease. And with the development of these newer drugs, where now on top of statin medications, people might be on 2 or 3 medicines, they're looking at what happens when people get their LDL under 70, under 50, even under 30. And it's showing that, because current guidelines would say we should get someone who has heart disease, get their LDL under 70. But we're learning that getting it under 50 actually further increases their heart benefit. And in Europe, they're pushing the guidelines to get people who've had heart events to get their LDLs under 55. So the lower the better. We don't have a lot of data yet with LDLs under 30, very, very low, but there are research trials underway evaluating that, looking at things like hormone production, cognitive function. Is there anything that negative that happens when the LDL is that low? To date, there's no proof of harm from that.
Wow, yeah, that's really interesting. Thank you for that insight. So we have a lot of questions about statin use, uh, um, and there are several questions about muscle weakness and other side effects. So specifically with the muscle weakness, is there any sort of recommendations that you have that could help improve that situation?
Right. So I think it's important if people have concerns that they're having muscle symptoms from their medication to discuss it with their provider. If it is statin, most often people describe that as soreness in their large muscle groups, like the thighs, arms, back, not so much distal extremities, more central big muscles. And it is reversible if it's the statin. So the main thing that we do is have people stop it for 2 to 4 weeks. Does it get better or not? Sometimes it's hard to tell because maybe it was just your back was sore and now it's better. We'll often retry it, go back on it, see does it recur. Sometimes then, oh, I am tolerating it fine. I can stay on this. So doing that hand in hand, because if someone truly is having a side effect, we'd rather replace it with a different medication. And there are different statins that are metabolized in different ways. So sometimes if someone has a side effect to one, they can take another one safely and feel well. So I would say don't give up. If you have muscle symptoms, talk to your provider about it and hopefully be willing to try one or two or three.
Yeah, certainly a lot of, sorry, there's a little echo there. Certainly a lot of factors when dealing with those side effects. And as you had mentioned, seeing your provider is certainly the best option. So let's transition into research. So you mentioned racial disparities in your presentation. Do you have any sort of information on gender disparities in terms of cholesterol?
In the research trials to date, women have been less well represented compared to men. Most research trials have about 30% women, and especially women of ethnic minorities are underrepresented in the current research databases. There's a lot of work to improve upon that. And it's what we're learning is that it's not so much that women of ethnic minorities are at higher risk, but instead they just don't have as much access to being involved in those trials, to being able to go to the doctor and take treatment. So there's studies underway to actually not just say, do you have high cholesterol or not, but reaching those communities, offering virtual appointments, offering events at churches and schools, things to reach out and improving access. So hopefully over time, not only will women be more represented in the research, but also just have greater access to clinical care.
Yeah, that is certainly true, and something that we are looking into as well at the foundation here.
Yes.
So another question, this doesn't necessarily have to do with research, but this attendee writes, do concerns regarding high cholesterol increase with age?
There's a trend or change in the cholesterol levels as we age. When we reach young adulthood to like our 20s or 30s, cholesterol levels start to rise. And then by our 60s, cholesterol levels are usually at their highest. And then as we become older adults, 70s and 80s, then those levels do tend to taper down again. It's kind of a complex interplay for reasonings why. In part, it's when we're in our 20s, 30s that people might start to gain weight, eat a less healthy diet, and as their dietary pattern and their weight goes up, their cholesterol does too. But there are also genetic parameters with that. And then in older age, we start to lose body mass, sometimes eat less, and then our cholesterol levels go down.
Yeah, that's really interesting, but it does make sense as you explained there. So I think we have time just for a few more questions, if that's okay with you, Dr. Tuohy.
Sure.
So again, going back to essentially research, but also the future of cholesterol management. What excites you most about the future of cholesterol management, whether that's research or some pharmaceuticals that are in the pike, so to speak, or treatment options?
That's a fun question. Well, I guess what excites me the most currently are some of the newer meds that are on the horizon that work in a totally different way and might have great benefit for long-term cholesterol lowering that are easier for people to take. Sometimes there's newer injectables that only need to be taken every 6 months. But the reason I just say I'm excited about it so far is that we don't have any long-term data yet. They're already advertising drugs like these, which I think can be a little misleading for people to like go on this brand new medicine that we don't have a lot of data yet. So I look forward to the trials coming out in the next 3 to 5 years to really see, do they work? Do they lower cardiac events? And the thing that I still remain hopeful for, even though it's so basic, is that I hope that people continue to re-engage with basic eating habits, eating better, exercising, because there's so much that can be done besides fancy pharmaceuticals to stay well.
Yeah, absolutely. Totally agree. So where can folks go to learn more about cholesterol research and treatment options? Do you have any, websites or any central location that folks can go just for additional resources?
Sure. For cholesterol education in general, I always uh, consider the WebMD website as a good source of reliable information. And then for research trial information here in town, the Minneapolis Heart Institute Foundation has a wonderful site where people can search for the research trials that are going on currently. According to subject matter, you can say, I want to learn about cholesterol trials, and they're all listed right there. So something accessible if people were interested in research.
Yeah, thank you so much for that, Dr. Tuohy. And I'm happy to put a link to our research website into the chat pod as well. So
Perfect.
those were the questions. Is there anything else that you'd like to say to our audience?
I just want to say thank you so much for attending and listening to this presentation. I hope it was helpful for you.
All right. Well, thank you very much, everyone, for spending the lunch hour with us today. We greatly appreciate your participation. Very special thanks goes out to our wonderful presenter, Dr. Tuohy. Thank you so much for your time and expertise. And as mentioned in the introduction, we're going grateful in celebration of 40 years of world-class research and education at MHIF. We do hope that you'll celebrate with us and consider making a gift in support of life-saving research as this remarkable year comes to a close. So if you would like to contribute to our mission, please visit the link that will be added into the chat pod now. And with that, Dr. Tuohy, thank you so much and have a great day, everyone.
Thank you.
All right.